I think everyone's on holiday, so Tom's not here, if anyone read right to the bottom of his email. So we're talking today about acute kidney injury and how we've been working in Tayside to reduce it. So I'm going to just start with a little bit about why acute kidney injury is important, what the implications are, and then I'll move on to a bit about the e-alerts that we've had in place for the last couple of years now. Just briefly mention the sick day rules cards and an update on the Scottish patient safety work that's been going on surrounding acute kidney injury. And then I'll pass on to Joe, who will talk about the education aspect and the AKI video that we've developed and the lanyard cards. And then David, who will finish with how we've been implementing a pre-operative risk score in orthopaedics. So the true incidence of AKI was previously unknown due to a lack of definition. There were several different definitions out there, and so nobody really knew what the incidence was. It's thought that in developed countries it could range from 2,000 to 4,000 per million population. It's very common in hospitalised patients and thought to affect 20% and up to 67% of patients admitted to the intensive care unit. We do know that the incidence of AKI is rising, but we're not sure why. Is it because we're more aware of it? Is there more of it around, or is it because there's an ageing population? So this slide just summarises how acute kidney injury and chronic kidney disease are related to each other, and summarises the adverse outcomes that you can have following an episode of acute kidney injury, and I'll go on to talk about these in the next few slides. So we know that patients who have had an AKI are more likely to have a poorer survival in the future, and mortality is high, and it's up to 80% in the context of multi-organ failure requiring dialysis. We know that as the severity of AKI increases, the mortality increases as well, as you would expect, with this study showing that an odds ratio of 8.6 in people with stage 3 AKI. Even mild transient rises in serum creatinine of low as 26 micromoles per litre, and as short a period as 24 hours is associated with poorer survival in the studies. And a large meta-analysis of 48 studies showed that AKI of any severity was associated with a long-term doubling of mortality compared to those patients who didn't have an AKI. So this is data from Tayside, and it's based on over 10,000 orthopaedic patients, the majority of who had a stage 1 AKI. And you can see that short-term survival is poorer with an adjusted hazard ratio of 2.36, but still in the long term, and this was a median survival of around 4 years, survival is poorer with a hazard ratio of 1.23, and this Cox model was adjusted for age, sex, diabetes, baseline renal function, and number of prescribed meds as a proxy for comorbidity. Another adverse consequence of AKI is the future development of chronic kidney disease, and this meta-analysis shows this. The top forest plot looks at risk of developing chronic kidney disease in the future, and you can see that after having an episode of AKI, the risk is greater once you've combined these studies. The second forest plot is looking at the risk of end-stage renal disease, and similarly the risk is higher. This is more recent data looking at the risk of having hypertension in the future, and in this study, patients who had an AKI in these filled-in bars had a greater incidence of a blood pressure over 140/90 up to 730 days compared to patients who didn't have an AKI. So again, another adverse consequence of having AKI. Cost implications, well, we know that patients with AKI will stay an average of 4.7 more days in hospital, and an economic study showed that the costs are estimated to be between 434 million and 620 million per year, which is more than the costs associated with breast cancer, lung and skin cancer combined. And it's thought that 30% of all AKI is preventable, and so we could potentially save up to 186 million if we prevented these. So you'll all be aware of the electronic alerts that we've had for the last 2 years. In Tayside, most of the other boards in Scotland haven't implemented these yet, and work is ongoing. So it's based on NHS England algorithm which used the Kidney Disease Improving Global Outcome criteria for AKI, and patients are identified via an automated comparison of the latest creatinine with the previous results in file, and really it's supposed to be a tool to highlight changes in creatinine rather than replace patient assessment. So this is the KDIGO staging that you'll be familiar with, and it's, the alerts are based on the creatinine criteria and colour-coded in this way on our ICE system. So you'll have seen these when your patients have had an alert. It comes up with a banner with a wee kidney and a thunderbolt through it. And then according to the level of AKI, then you'll get a different colour banner across the top of your patient. You can action the alerts, and we probably would encourage people to do so, although we have been auditing this, and initially when we do the education, people do action the alerts and then it tails off, but it's a useful way for us to know what's been dealt with, and also clear the alert once you've dealt with it. And the alerts link to our guidelines on the intranet, so you can click on and get our guidelines. And similarly, there's a primary care guideline as well, so when an alert is generated in primary care, the GPs get the primary care guideline coming up. So do they work? Well, this paper was quite interesting, and it looked at the alert in combination with a care bundle. And so this interruptive alert came up electronically that the clinician needed to complete before they could proceed, and if they weren't completing it, they had to state a reason why they weren't completed it. And the group in Derby implemented this with 4 monthly junior doctor education. They did propensity score matching, and they looked at 3,717 episodes in over 3,518 patients. And they found that survival was better in patients who had an AKI with a care bundle completed within 24 hours. This is a recent meta-analysis of e-alert studies, and when you look at all the studies looking at e-alerts, almost 2,000 patients, there's no difference in survival, but that's the e-alert on its own with nothing else. So more evidence is required, but it is clear that these alerts need to be implemented with education, possibly other initiatives such as care bundles, and we need to look and see whether they are making a difference, and we're currently doing this just now in Tayside data. So I'll just move on to briefly mention the medicine sick day rules. These again were rolled out in Tayside, and we modified the national ones. They have been given to community pharmacies, general practices and outpatient clinics, and really encouraging patients to stop certain medicines when they become unwell. We recommend that these are given out with counselling. We don't suggest that they're just given out to patients without any information or without somebody speaking to them, because I suppose the worry is that patients will stop medicines and not restart them again. But we have a supply of these at the moment, so if anybody needs any for any patients, just like any clinics, then they can just let me know and I can supply some. So I'll just end on talking about the Scottish Patient Safety AKI Collaborative. So on the back of a 90-day process, they highlighted that AKI was an important new focus as part of their deteriorating patient workstream. And so they set up an expert reference group, and a lot of the initial testing was done here in Tayside. So the plan is that they were holding interviews of interested health boards in AKI in May, and they have now recruited health boards and are planning a launch at the end of August with members of these health boards to move forward work across Scotland in AKI. So their aim is to reduce harm to people in Scotland with AKI by reducing the incidence, length of hospital stay and reduced mortality. They want to reduce risk, improve recognition, improve response and review, and improve recovery, and allow teams to deliver reliable care for people with AKI. So their measurement plan that they have at the moment is looking at unadjusted mortality within 30 days of admission with people diagnosed with AKI and the incidence of AKI in patients admitted to hospital. At the moment, there's still discussions of how this is going to be measured because coding is very poor and most hospitals don't have the alerts, so they can't measure it in that way. They also want to look at the median length of stay in patients with AKI. So their process measure is time to completion of a bundle so a response and review bundle which they have developed. So this was developed by Scottish Patient Safety. We did a bit of testing here in Tayside in the urology ward and in surgical receiving. So it's split up into two aspects. There's a response, which they've called a shout bundle, and then a review, which is the bump. The plan is for these to go as stickers into the notes, but further work is needed to test these in other areas such as MAU. So the following health boards are participating, and the launch is on the 25th of August. So there may be, you may come across testing of various aspects of this work within your clinical areas. So I'll pass on to Jo, who's going to talk about the education aspect.
So for those of you who don't know me, I'm Joanne Sloan. I'm one of the renal registrars here in Tayside. And as Dr. Bell has already mentioned, I'm going to discuss what has affectionately come to be known as the AKI video within the renal department. Now, before I focus in on the video, I'm going to talk a little bit about some of the education that has been done by our team over the last few years around acute kidney injury. I'm sure you recognise some of these images, having maybe met us during our Acute Kidney Injury Awareness Weeks, which we ran both in 2015 and then a few months ago this year. Lots of educational activity occurred during those times. We had information stalls that we manned for a week at a time, catching lots and lots of members of staff from NHS Tayside. We used posters to give information to people. We had different ways of just trying to increase the awareness of an acute kidney injury. So we had lanyards that we gave out, bottles for water that we gave out, and also we went out into the wards to meet the clinical staff. Mainly in 2015 we did this because at that point we were rolling in the e-alerts and we had to give some education around what these were, how were you going to deal with them. So the team went with the trolley into the clinical areas, which allowed the members of the team to just come away from their busy work for 5-10 minutes, take a drink and have some education. And this was really effective. As Dr. Bell's already discussed, we had the sick day rule cards, and in collaboration with our GP colleagues, we rolled out these cards in 2015, and a little bit of media campaigning was done at that point to raise the awareness among patient groups as well about these cards and also awareness among other medical staff. And this is a picture of one of our GP colleagues proudly holding said card. We also had a bit of interest from the BBC and more media coverage again at the time of the introduction of the e-alerts. And again, it's just raising the awareness. And as you'll see, Dr. Bell and Dr. Jennings pictured here. In 2017, we added more ways of increasing educational awareness of acute kidney injury, and Dr. Lim, one of the other registrars, developed a really nice, essentially credit card-sized lanyard card, double-sided in nature, which really was a condensed form of the guidelines that you can carry with you all times of day and night, just revising risk factors, history, examination, the tests, etc., etc. And these proved really popular this year. And I see multiple members of the medical and nursing team carrying these with them on a daily basis. But we were aware that, a couple of weeks of education every other year, you're not meeting everybody, we're not capturing an entire audience of everybody that we needed, and it's very labour intensive. Could we develop something that is accessible for everybody at any time of day or night? And we thought about, what sort of online material could we come up with? So we thought maybe we could record some form of simulated patient encounter. At the time the idea came up, I was working down in clinical skills. We had to think about that, but it just didn't feel right. What about maybe an online lecture, maybe a podcast? But we wanted something that was quite engaging and dynamic and fresh. And there's increasing numbers of online kind of animated tutorials that are coming online. Quick, easy to view, and getting important points across quite quickly. So we decided to bravely start onto this. And there's a whole team behind us developing this. First of all, what we had to do is we had to write a script. So we did. And there were 3 main authors involved in this. At the centre of this was one of our 4th year medical students called Ross Norris, who's with us in the audience today. And as part of his 4th year project, he developed kind of the core of the script that then the rest of the team have edited and added to. We had to find somebody who could draw these animated images that we wanted, and that was one of the biggest challenges. You can imagine that the renal team have many talents, but it appeared that none of us could draw. And it took a little bit of time to find somebody with the right style of drawing, and we were really lucky to find a very talented local artist called John Hunter Barry, who'd worked for DC Thomson for years and more recently has helped the Our Willie campaign, drawing some of their images for the PR aspect of that campaign. We also managed to source a really talented videographer called Emma Jane Alexander, who works part-time for the university but also freelance does video work, and is a very talented, as I say, filmmaker and editor. There's obviously cost associated with anything like this, and we were very fortunate that the Renal Endowment Fund had faith and trust in us to give us enough money without actually ever having done anything like this before to proceed with this. So just to give you a little bit of a background of the process, it wasn't a very lengthy process, but it did take quite a bit of work. We took about 2, maybe 3 months to write the script, to polish the script, and then a further 2 months to put the what we call the storyboard design together. Essentially what we had to do is we had to create lots of drawings and images that would stick in the mind, would put a point across, and then match these to the script. And timing was of essence with that, and you'll see that in the final product in a minute. We then had to do filming of the actual animation, and that took about a day and a half. And this is just some images of John and Emma hard at work down in the University of Dundee recording studios. The next point was to do the voice recording, which took approximately half a day, and then the editing process where Emma took over, put everything together, and then started sending it back and forth to the team, who made suggestions multiple times, and her patience, I can tell you, was somewhat tested by the end. So I'm going to show you a little bit of this video now, just to whet your appetite. I'm not going to show you the whole thing. Now, let me see.
So what is an AKI? An acute kidney is an abrupt decline in renal function. It is defined by an increase in serum creatinine or decrease in bone movement. It can be classified as stage 1, 2 and 3, with stage 1 being the least severe but most common, and stage 3 the most severe but least common. Each stage is defined by changes from the patient's baseline creatinine, with stage 1 an increase of 1 to 1.9 times the baseline, stage 2 an increase of 2 to 2.9 times the baseline, and stage 3 an increase greater than 3 times the baseline, or the need for dialysis. Many hospitals will have an electronic alert flagging patients with an AKI when they are looking at blood results. So why is an AKI important? To put it simply, if your patient has an AKI, they are at increased risk of dying. In fact, if they have an uncomplicated AKI, the chance of dying is as high as 10%, with this rising to 80% in the context of multi-organ failure requiring dialysis. It is therefore obvious why we need to try and prevent AKI in the first place, and recognise really early when it does occur. There are lots of people in the community and in hospital who can develop an AKI. Are we able to identify those most at risk? The answer is yes, and recognising these patients is an essential part of preventing it.
So we'll leave it there. And I would strongly encourage you to go and watch this in your own time. Now, So, in terms of where are we only actually launched this live a few weeks ago. We're in the process of rolling it out. It currently is available on the NHS Tayside YouTube site. We have done an email distribution of the link to the video to all foundation doctors within NHS Tayside, our hospital at night team, our patient safety team, district nurses, the renal team both locally and nationally. We're trying to roll it out. And once the medical students return from their summer break, then we will email them as well. It's also starting to gather some momentum within the social media forum. It's on the NHS Tayside Facebook page, and we have over 900 views so far, and there are also some Twitter activity around it. So the word is getting out and people are viewing it. What's the future? We now have developed a sustainable educational tool that we can use in the future. We can use it in future AKI awareness weeks. We will continue to use it at all FY inductions, and we certainly are doing that this year. It can be used for nursing staff, medical staff. Anybody can access this at any point. And I put in a very small letters at the bottom, query more. We may develop other videos around other topics related to acute kidney injury if the feedback from this one remains really positive. And that's it. Thank you. I'll hand over to David now.
Good afternoon, my name is David. I'm another one of the renal registrars, and I'm currently actually doing a general medicine rotation in Perth, and I'm going to talk about an AKI scoring tool that we're currently rolling out in PRI at the moment. It goes back to work done by Dr. Bell that was published in 2015, and really the work done was to develop a scoring tool that could be done on patients pre-orthopaedic surgery that would predict the risk of an acute kidney injury post-operatively. And it was actually done using local data, so the score was developed using data from Ninewells and Stracathro, and then it was validated using data from PRI. And obviously the aim of this was if you could identify patients pre-operatively who were at high risk of acute kidney injury, then it would allow for earlier intervention and really to optimise their perioperative care with obviously the aim to improve their outcome. And in the paper, Dr. Bell's paper, the rate of AKI was a little bit higher in the Ninewells-Stracathro group at 11% compared to 7% in the PRI group. And this slide really illustrates the points that Dr. Bell was making at the beginning of the presentation of really if you've developed an acute kidney injury, then the outcome being poorer. And this shows that really survival was worse both in the short term and in the long term for patients who developed an acute kidney injury. So in the final scoring tool came up with 7 predictors that were, none of which were particularly surprising. So obviously age, gender, so males being at higher risk of acute kidney injury, patients who had diabetes, baseline EGFR, patients being on an ACE inhibitor or an ARB puts them at higher risk of acute kidney injury, the number of prescribed medications, and that is essentially a proxy for the amount of comorbidity patients have, and the ASA grade, which is the American Society of Anesthesiology grading score, which I have to say as a medic I wasn't familiar with before I got involved in this, but it's very straightforward, really a scoring tool between 1 where patients are completely healthy and 5 where they're moribund essentially. So in terms of rolling out the score, we've done a few things in terms of implementing the score. The first thing we've done is we've turned the score into an app, which can be used both on your phone and on a desktop, and it's really very easy to use. I've just put up an example here of a 65-year-old male who has diabetes, but normal baseline renal function with an ASA grade of 2, which you would get with diabetes, who's on an ACE inhibitor and is on more than 3 medications. And as you can see, you get a score at the bottom where his predicted AKI risk would be 23%. Because we're aware that many of the junior doctors won't be familiar with the ASA grade, we have that built into the app. So if you just press next, you get a breakdown of the ASA grade to use. The other thing we've done is we essentially did a baseline audit just to establish what current practice is currently in the orthopaedic department in Perth. And I'll just give you a few of the highlights from that, really. I looked at a snapshot of 2-week period from June last year, so looked at 37 patients, and really what it confirmed was the calculator is very easy to use, it's very reliable, the app didn't crash or anything like that. We think essentially from the data in Dr. Bell's paper, we think if we use a cut-off of greater than 10% as being patients at high risk of AKI, so if your AKI risk score is greater than 10%, then you're at high risk, that'll essentially mean 40% of all patients. In this group, in this snapshot, it was slightly higher than that at 47%, and 3 of the patients had an AKI risk of greater than 20%. What did we find? We found that patients aren't routinely fluid reviewed post-op in orthopaedics. We're not suggesting that necessarily everyone needs a fluid review post-op, but perhaps more surprisingly, patients who had hypotension post-op, so 9 patients had a systolic blood pressure of less than 100 post-op, 5 of them actually had a blood pressure of less than 90, but only 3 of them had a documented review by medical staff. Fluid balance monitoring was variable. Only 23 out of 37 patients had an accurate fluid balance chart. 16 out of 37 had IV fluids prescribed, 1 was getting a blood transfusion, and 5 were catheterised, 1 for retention, 4 for fluid balance monitoring. In terms of medications, obviously very important, being risk factor for acute kidney injury. Their non-steroidal anti-inflammatory use was essentially was appropriate. It was getting withheld perioperatively, and when it was being used for pain post-op, it was in low-risk patients, with one exception for a patient who was palliative. More interestingly was what we found with the ACE inhibitors and ARBs. Essentially, the standard practice in Perth is that you get your ACE and ARB withheld on the day of surgery, but it's restarted on day 1 post-op. And what we found was in the 5 patients that this applied to, who got it restarted post-op, 4 of them then got it withheld again subsequent to that because their blood pressure was so low, which suggests to me that really starting on although it's small numbers, it strongly suggests that starting it on day 1 post-op is really too soon. Again, in terms of measuring renal function, post-op was quite variable. 7 patients didn't get any bloods post-op. Most of them were low risk of AKI, but there was 1 patient who was in for over 2 weeks and didn't get any bloods checked after an ankle fracture. So the next thing we've done is come up with an intervention bundle. So for the patients at high risk, what do we want? What do we want to happen, essentially? Now, we've gone for a relatively low cut-off, so above 10%. If your pre-op AKI risk is above 10%, then we've judged you to be at high risk. And the reason why we've picked quite a low threshold is because the intervention bundle is really readily achievable. We're not asking for anything dramatic. The first thing is to ensure that patients keep well hydrated, and so for the nursing staff on the ward to make sure that these patients are getting accurate fluid balance. We're not suggesting that everyone be catheterised. That might be appropriate for other reasons, but we're not suggesting that all these patients be catheterised, but we do have an accurate record of their input-output to ensure that nausea and vomiting is well controlled, and that's just to make sure that patients can maintain good oral intake of fluids, and that you should consider IV fluids if oral intake is poor or there are any signs of dehydration, and that may well be if someone's hypotensive, it may well be they need fluid resuscitation. The next thing is in terms of what to do with medications perioperatively. So we're suggesting that certainly all the patients who are in the high-risk group, that the ACE inhibitors and ARBs should be withheld on the day of surgery, but also 2 days post-operatively. And that really, at that point, on day 3, someone should be looking at the blood pressure and deciding whether or not it's appropriate to restart it at that stage. If the blood pressure is 90, then it may well be appropriate to delay it further. Obviously, fluid balance has been very important perioperatively. We've suggested that everyone who's high risk gets their diuretics withheld on the day of surgery, and that advice would be given in pre-assessment clinic. Of course, when the patient comes in, if the medical staff or anaesthetic team see the patient and decide actually they're at high risk of heart failure, then by all means they can give them the diuretic, but that's a positive decision to do that. And then the non-steroidal advice is actually the same as what it is for all patients, and that's to withhold it for 3 days before surgery and to use with caution post-op. In terms of monitoring renal function post-operatively, the orthopaedic team will say that everyone gets their bloods checked on day 1 and day 3 post-op. When I looked at it, it wasn't the case. But certainly everyone who's high risk should get their bloods checked on day 1 and day 3 post-op. And this isn't just hips and knees, this would be any orthopaedic procedure. There's obviously a push to get patients out as soon as possible, and there's a big push for patients getting elective hip op to get them out on day 2. Of course, we wouldn't suggest keeping patients into day 3 just to check their bloods, but if they are going home on day 2, then they should get their bloods checked on day 2. Because when you look at when patients get an AKI, if we just checked them on day 1, then we would certainly miss a reasonable number of patients. And obviously, if someone gets an AKI, they might need more frequent monitoring. So how will it actually work? So for the elective patients, the pre-assessment nurses will be doing the score, and anyone that's high risk, they'll put a sticker on their notes. For the emergency patients, obviously it'll need to be the clerking FY doctors that do it. Actually, in the meantime, because there's going to be a lag between patients coming through pre-assessment and actually getting their operation, the FY doctors on the ward are also going to do it for elective patients that haven't had the score done in pre-assessment. So this is the sticker that's going to go on the front of the notes, and I'm also keen for it to go on the drug chart as well, so it's very clear. For the elective patients, when the secretaries see the sticker on the front of the notes, they're also going to add it to the theatre list, so it will be on there along with patients having diabetes, for example. It will also be starred that they're at high risk of AKI, so the theatre staff and in recovery, they'll be aware of that as well. And then in terms of the intervention bundle, I've got a poster on the next slide. So the poster will be going up in the relevant wards and in pre-assessment, but also an A4 version printout will be going in the notes. We've specifically made the decision that it's not going to be a checklist, it's going to be there as a reference, and hopefully people will become a habit and people will just do it. It's also built into the app, what we want our intervention bundle to be, and it'll be available on StaffNet, so it should be very clear. This is the poster, so it's obviously got the interventions I was talking about. It's got a QR code, so if you see the poster and you scan it with your phone, it takes you straight to the app, and it's got some added information about how to assess someone's fluid status and when you might consider urgent fluid resuscitation, and one of them obviously is a low blood pressure. And there's also a link to our AKI guidelines for patients who develop an AKI. So I've met with the orthopaedic and the anaesthetic teams in Perth, and I have to say they're all very keen and very supportive. We started it in pre-assessment clinic a number of weeks ago, and it seems to be getting done. The nurses are doing it, and it's not adding significantly to their workload. And then the FY doctors have started doing it this week, and again they seem to be doing it with no major issues identified. So obviously we're going to be keeping a close eye on things for the next few weeks and months, but all being well, we plan to roll it out into the other sites, so in Ninewells and Stracathro, hopefully later on in the year, all being well. Any questions on this, or indeed any of the other talks?
So I've got a number of the lanyard cards with me today if anybody needs one, and as I said, we've got the sick day rules cards, so if you give me a shout if you need any for your clinical area, I can give you some. Happy to answer any questions. Dr. Lafferty.
One of my questions was in relation to patients fasting. We seem to, particularly in trauma list, can go on for a long time, you know. And there has been work done in general surgery about limiting the amount of time patients fast and therefore are less likely to be dehydrated or intubated. You know, if there's any work like that going on in the index?
Not specifically looking at that and looking at the delay of, I'm not aware of anything specific. Obviously, if people are know by mouth and they're waiting to go to theatre, then.
I think within general surgery, there's been work done. They're fasting for 4 hours, and they won't. If they know they're going to be last on the list, they won't start fasting at 6 in the morning. I wonder if similar.
That's not actually been highlighted. I'm not aware of any work being done on that, but it's an interesting one.
Thank you very much.